So welcome everyone to our first, I hope, of many AAES Virtual Surgeons Lounge. This was an idea from the IT committee since we missed our annual meeting this year. We decided to have this virtual lounge dedicated to discussing issues surrounding COVID-19 and our profession as endocrine surgeons. So thank you all for joining us. We have our esteemed panelists here. First off, Dr. Siperstein, Dr. Allan Siperstein, who's the president of the AAES and chair of endocrine surgery at the Cleveland Clinic. Dr. James Lee, professor of surgery at Columbia University. Dr. Solórzano, Carmen Solórzano, professor of surgery at Vanderbilt University and chair of surgery. Dr. McGill, staff surgeon at Emory at Decatur, and Dr. Peter Angelos, professor of surgery at the University of Chicago, and our ethics expert. So before we kick things off, just a few housekeeping items. As you all have realized, all of you attending the conference are muted upon arrival. Please use the Zoom webinar chat box to ask questions. Just type them here and we'll get them to our panelists. For people who can't sign on either because we're full up to the capacity or aren't able to attend today, we'll make this recording available on the AAES YouTube channel. So welcome, and Dr. Rohit, Ranganath, and I will be moderating the conference. Or I should say our lounge. So we'll hope to get some different perspectives here on the following topics. The recently published guidelines for endocrine surgery prioritizations during COVID-19. We'd like to hear from everyone, especially James being from New York, about some of the lessons learned from the front lines of the COVID pandemic. We'll tackle some of the ethical issues that have come up for decision making in the pandemic, and also exploring some ways in which our profession, meaning endocrine surgeons, have been redeployed, and some of the new roles we've taken on, both in the academic and private practice setting. So welcome, and Rohit, let's get started.
Thanks, Geeta, for the great introduction. Off the bat, I would like to start off with a question to Dr. Siperstein. Kudos to you and all the committee members to putting off the guidelines at a very early stage of this pandemic. I just wanted to know what were the considerations that went through when you decided to put out these guidelines.
I can give you a little background on that, but first I'd like to say welcome to everybody, and I wish everybody is doing well, and my best to everybody's family and loved ones during this very difficult time. And thanks for the organizers to put this together. I can give you just a little bit of background about how this hit our radar. In the state of Ohio, our governor was actually quite quick and proactive about closing schools way back on March 17th, if you can remember back that far. And at that same time, he announced but hadn't given written guidelines in terms of closing down elective operations. And he had basically 4 mandates in terms of prioritizing surgeries: threat to the patient's life, threat of permanent dysfunction to an extremity or organ system, the one that is really relevant to us, risk of metastases or progression of staging, and then risk of rapidly worsening or severe symptoms, where there's a great time pressure to do that. The mandate from our institution came out that evening, and so I had to very rapidly scramble and flesh these out and try to give my docs a little bit more of a granular direction in terms of how to answer these. And I needed a response from my docs that night, because our institution basically decided overnight to go ahead and enforce these mandates, even though they hadn't been officially sent in writing from the state yet. And it's interesting because I went back and pulled my email message, and I said, well, the one that really speaks to us the most are the whole issues of tumor progression. And one of the things that I wrote, and I hope some of the other panelists will comment on this as well, but I said it does not address patient anxiety related to waiting to have cancer surgery or for anxiety related to any of other procedures being delayed. And I thought that was kind of a twist that really wasn't addressed in the guidelines. As the leadership of the AES met, it quickly became apparent that we were doing a lot of parallel processing in all of our institutions, and had some informal discussions about how we were interpreting both state mandates in terms of restricting surgeries, as well as our own institutional interpretation. So there's a lot of scrambling going on. And the group, very quickly suggested, well, why don't we just kind of throw our suggestions together? These aren't official AAES mandated guidelines in any sense, but simply sharing of what our practices were. And so those were thrown together and sent out initially as an email message. As that was going on, it was interesting. I got emails and messages, and I'm sure a lot of you did as well, from as far as France, asking about, well, what are you doing? How are you, addressing ramping this down? And so then essentially morph that email message to post to our website. So in essence, they really were not done as formal evidence-based guidelines. They simply were a shared practice from several of our institutions. And we understand that they would be constrained by, as I say, both institutional and state mandates. So that's how we kicked all this off.
Great. In terms of, there is a wide variability, I must say, in the number of cases all over the country. Were any of the community surgeons involved in putting out these guidelines among the committee?
No, well, for these particular ones, I mean, it was really a back of the envelope, AES ad hoc, leadership group that kind of shared our practices. Interestingly, I had several community surgeons reach out to me individually as well through email, some AES members and some not. And they were really asking for, for us, we kind of got guidelines or mandates from our institution. And it'd be interesting to see what the other panelists or the audience, how they react to this. Got relatively little guidance from their own institution. Were kind of left to their own devices to interpret things. So I think there was kind of a wide spectrum of how this was initially interpreted as well as rolled out.
And I think it's important to just keep in mind that, these are not guidelines, as Allan is saying, that they're not evidence-based. I mean, there's essentially no way that we could put out evidence-based guidelines in such a unique situation. I think the other thing to keep in mind is that this takes into account the multiplicity of presentations in different people's institutions. So in some areas, things were happening very precipitously, whereas it's been a slower burn elsewhere. And so we tried to straddle that line to make sure that places where you could still do elective surgery, we didn't want to be too restrictive in our suggestions. And again, it also took into account that the PPE or the protective equipment situation was a much different scenario, a month or two ago than even just yesterday. So interesting corollary to Allan's point about natural history. So Carrie Lubitz is organizing a multi-institution look at exactly this question, not only, what was the progression of disease in these patients who had delayed operations, but also a component of, how they felt about it and the quality of life issues that ensued from it.
Mm-hmm. So I may just want to add on to those comments that initially conserving PPE was a clear driving factor. And then our institution and many other places around the country quickly did modeling in terms of what resources would be used up when, based on how rapid the rise in the curve would be, what would we run out of first? And interestingly, there were concerns about personal protective equipment. And so obviously everybody scrambled to look at, reprocessing, establishing how long, cohorting patients so that equipment could be worn for a longer period of time, reducing non-essential personnel on those wards and in the operating room, et cetera. There were restrictions in terms of number of ICU beds do you have? Obviously, everyone's been talking about ventilators. Interestingly, when we did our modeling at the Cleveland Clinic, the thing that we were going to run out of first, our rate limiting step, were nurses to take care of the patients. And that really became an issue. And so we very quickly repurposed a number of personnel at all levels, including having recently retired nurses come back for training. And obviously a lot of the docs, and I know James has been working, doing ICU and general surgery work. So we have all been repurposed as well. But I thought it was really interesting that at least at our institution, nurses were going to be the rate limiting step for patient care. Fortunately, we have not seen a surge to the magnitude that you unfortunately have had in New York, James.
I think that was well put. The fact that at first we were all worried about personal protective equipment, which was a real worry because the supply chains were different, and we didn't know where we were going to get all the stuff. For the normal supply chain, many was coming from China. So we were worried about not only the PPE, but also the personnel, the safety of the patient and the safety of the healthcare worker. It's interesting, our governor was slow to pull the trigger, so to speak, but the area around our institution and even our institution began this process fairly early, but there was no clear guidance as to what an elective case was, except for that's the way it kind of came out. We got to stop doing elective cases. So immediately talk to all the different services to see, what can we actually begin to postpone, if you will. And obviously cancer, what cancer can you postpone? And so that was a kind of a struggle at first. Emails flying, chairs at different institutions were talking about it. And in the end, it kind of went down to, well, what can you postpone for 2 to 3 months without really hurting the individual? Obviously, there were some patients, breast cancer patients and even thyroid cancer patients who were very nervous, as Allan was mentioning. So.
Great that you brought it up, Dr. Solórzano, about my next question for the panelists would have been, how do you manage patient anxiety? Has anybody on the panel operated on patients just for anxiety?
No.
My answer would be no. I mean, our institution was quite systematized and rigid, and I actually serve as chief of surgery at the hospital. We do most of our endocrine surgery, and my job was to review, and it still is, to review the operative schedule every single day for all cases being done, and it often takes review of the medical record, et cetera, to make sure that they fit under guidelines, because the concern, at least from the state, is there is the potential for some external auditing to make sure that you are meeting these guidelines. And for better or for worse, and interesting, discussion, because there are people that are a lot more expert than I am at this, is this whole issue of what is the negative impact of anxiety or delay?
I think one thing.
Other.
Go ahead.
Sorry, go ahead.
It's okay. One thing I think has made a big difference is rather than just having my schedulers call and cancel the people or tell them their surgery is going to be delayed, I think talking to them individually, and I've even checked in with some of them once a week to just say, we're not forgetting about you, because I think just them floating out there in the world quarantined is like the worst combination of them just stewing in their houses thinking about their cancer. So I think the personal phone calls have made a huge difference with the anxiety.
I think that was a great point, Julie, about talking to your patients directly. We did that to call the patients and explain, And for the most part, they're very receptive. There are some patients that were very nervous and anxious about it. But that is an absolute point, great point, which also segues into, I'm sure we're going to talk about this, but also calling your referring physicians that you're here to help and keep in communication with them. But this is more thinking about reemergence out of this and how we're going to do that. That's
I think
complicated.
We should be careful though, because there was a couple times now we've used the term elective surgery, and we know that elective surgery is different from emergency surgery and urgent surgery. But I don't think that our patients and necessarily other doctors know. And so one of the things that we've begun doing at the University of Chicago is referring to surgery as medically necessary, time sensitive. And so, there are some things that are medically necessary, but they are not time sensitive, and others where, the timing is a little bit different. And so, so I think it's helpful to be very precise when we talk about this with our referring doctors and even with our patients, because if you tell a patient your operation is elective, they get the feeling that somehow we don't care about them. But if it's explained to them in the context of helping to ensure that they will have the best outcome, ensuring that it's good for the public as well, I think it goes better.
The next question would be, how would we deal with the issue of liability arising from a perceived delay in care?
I think part of it depends on where you're at. So in New York, when they declared a state of emergency, a week or so later, the governor basically invoked emergency clauses to say that liability for decision-making during this time would be less prosecutable, essentially trying to give physicians and healthcare workers cover for the decisions they made. And I think that extends broadly to essentially any medical decision that's been made during this this period of time. Not that that is foolproof or ironclad protection against suits, but I think part of our decision making as to what is urgent versus which is time flexible, I think goes into that as well.
I know all the cases on the elective schedule have been cleared out right now to operate only on the absolute necessary. Once the operating rooms reopen, is there a formula that any of you have come up with on how to triage these cases?
Well, you may have been spying on our committee meetings today since you asked that question.
No, I
because
think it might have been Dr. Milas.
That's all good, Dr. Milas.
Oh, Milas is always spying on me, so that doesn't count. So, no, so we begin, as our curve is starting to flatten, and we're realizing that at this point, we do have resources and a little bit more bandwidth to provide care. That exact, question came up. We have no mandate yet, but we're starting the discussions. I think the bottom line, it's going to be a little bit of a matrix of medical prioritization with first come, first serve. And so we're working on some type of matrix to balance those things. That said, we have a backlog of patients that could keep us operating all day Saturdays as well right now. Interesting, if we look at the pipeline a couple months out, despite the fact we're very aggressively doing virtual visits and trying to keep the pipelines open, the patients aren't lining up for, quote, new virtual visits the way they used to. And so we see the pipeline farther down the road actually being with fewer patients. But at least we're going to have a glut in the short term. And I'd be interested in other people's observation on that.
I think this is something we're starting to think about it, just like you are, Allan, and I'm sure everyone's institution is at least thinking about it. We got to be very careful, obviously, because I'm not sure that we've reached the complete plateau here in Tennessee. or peak, or whatever you want to call it. I think it's a plateau. So how that's going to look, returning to some semblance of normal, which I'm not sure that we will in a while. How many, are patients all going to be tested before you take them to the operating room? I think we're looking at something like that. How long is that test worth? 3 days. If antibodies ever come in to be tested, are they reliable? Who to operate on? Let's say cancer patients with multiple comorbidities, they're a much higher risk if you operate on them and then they get COVID, say. So it's a complex issue that the command center is working on right now at our institution. So a lot to think about. And then there's a backlog of cases, of course. And so many of them, I suppose, are not urgent or time sensitive, as Peter said.
And I think when you start thinking about how you open it up, there are going to be phases in how you open up as well. And so in the early phase, as you're still trying to get patients out of your ICUs that have been, ORs that have been converted to ICUs, et cetera, there actually may be a golden period of time where endocrine surgery is actually prioritized, because we don't require a lot of resources, blood, ICU beds, step down beds. And a lot of us do outpatient endocrine surgery. So there may be this period of time where endocrine surgery may have a heyday prior to opening up once, ICUs start to empty out.
Very good point, James. And actually, before we move to the next topic, I would like to have Dr. Angelos weigh in and tell us about the resource he just put in the chat box, which might help us in prioritizing cases. Dr. Angelos, if you want to just give us a brief description of that. And
yeah, sure. This is with some of my colleagues in the Department of Surgery. We essentially came up with this way to sort of score cases, and it's dependent on the procedure itself. Sort of how long is it going to take? What is the likelihood of needing to go to the ICU? What's the likelihood of needing blood or blood products? That sort of thing. And then one aspect of it has to do with the underlying disease. And so that's, some estimation of the likelihood that the patient would be harmed if their operation is delayed by 2 weeks, or if their operation is delayed by 6 weeks. And then the final thing is looking at the actual patient characteristics, the age of the patient, whether they have underlying medical conditions. And it's just sort of a way of quantifying things so that you can compare cases. And we thought it was helpful. It was, we had been using it for a short period of time, and several of us kind of put it together. Vivek Prashand was my colleague who wrote it all up and got it accepted at Annals in a record time.
thank you, Dr. Angelos, for that. I'd like to switch gears just a little bit, and since we have James, who's been in the middle of the thick of things, as it were, one of the epicenters, I just wanted to hear James's accounts, and then also from the rest of the panelists. James, what are the biggest takeaways you've taken from, being at one of the frontline hospitals at the epicenter? That will be applicable to all of us, but maybe specifically to endocrine surgeons.
I think that from a system-wide standpoint, the two main takeaways that we've seen the value of, number one, is what Allan mentioned already. If you think about the healthcare system as a pyramid, we physicians like to think of ourselves at the top of the pyramid, and that we sort of run the show. But really, at the base of the pyramid are people like respiratory therapists, our nurses, especially our critical care nurses. And the dam seldom breaks from above. It always breaks at the base, and that's when you have a true disaster. And so the thing that we're recognizing or have recognized is that we have plenty of physicians. There are plenty of physicians who can be repurposed, redeployed to whatever job. It's really the nurses, especially nurses who can take over the role of ICU nurses, which is the real rate limiting step in all of this. And so, they've done a tremendous job, stepping up. So we have recovery room nurses, we have nurses from the floor who haven't been in the ICU in, 30, 40 years stepping into those roles. So I think the big system-wide message is to beef up your nursing corps, prior to reaching the exponential growth phase if you can. I think the other main lesson that we learned clinically is hyper-specialization. So you will have a lot of people volunteering to help out in whatever capacity you need, but I think the key is hyper-specializing people. And step into a role that's very broad, where they have to learn lots and lots of different components to that job, I think is very difficult for people. But having people learn one very specific task and getting very, very good at that in a short period of time, I think is incredibly invaluable. So one example is for our ICU patients, a lot of those patients require prone positioning, which is a very resource intensive, lengthy, dangerous process. So early on, we organized our physical therapy teams to become basically prone positioning teams. So they had very few people who they needed to walk around the hospital, but they organized into this task force where you would just give a call number, and this prone positioning team would show up. They would prone position your patient, and the nurses were free to do all the other things that they needed to do, all the other care that they needed to do. Similarly, for surgeons in particular, we created what we call SWAT teams, where it's basically just a procedure team where you have surgeons who just go around the hospital doing A-lines, central lines, Foley catheters, whatever it takes. Anything you can do to decompress people's workload and allow them to focus on things that only they can do, I think is incredibly important. So I think those are the two main things that we've learned, from the clinical side. And I think the other thing that, is really heartening to see is that in times of crisis, people really step up. And it's been amazing to see how many people have volunteered for jobs that they don't really do on a daily basis. And it's amazing to see how physicians and healthcare workers from across the country are helping out. So just yesterday, a team from Cleveland Clinic and UCSF came into New York to help us staff our ICUs, which was incredibly welcomed and just such a godsend in this time.
Okay. Thank you, James. We have a couple of other questions and may have addressed this, but what are people's thoughts on when we do open up, and start sort of re-triaging patients that we talked about before? Do we anticipate that all of them will still get tested for COVID? What are the plans at your institutions? What are we going to say as a society, since we are doing, elective type surgeries when we do reopen? So we'll start off with Allan and go from there.
Right, so we've had a lot of discussions about exactly what you're talking about, and the pendulum swings based on the availability of tests, and particularly more recently, rapid testing. As you know, there are a number of different platforms that are out there. Very often it may be machine limited, or in particular our institution, reagent limited in terms of how many patients you can run through. So whatever equation you come up with today, for example, one of today's discussions was if you have patients that require urgent surgery, not this minute, but within 24 hours, or broken hip, things like that, can we test those patients before we bring them to the operating room today? As you probably have all been aware, the testing is imperfect. There are people who are absolutely asymptomatic who are shedding virus, and we have cases where people clearly fit the symptom profile, very strongly suspected that they had COVID. Their nasal swabs were negative. A day later, bronchial swabs were positive. And so it's not going to be a clear problem in a process in evolution. Yesterday, I was in a seminar dealing with the whole antibody testing. And if you ever want to get depressed, you could find this lecture. Very complicated, you know, going through the initial IgM curve and then IgG. It is clear that you can have IgG titers, but still be shedding virus. And the whole question is, are those specific IgG subtypes, do they basically kill the virus, or are they just kind of living in your bloodstream, not doing very much? And the whole very difficult concept of transfusing convalescent patients who have high antibody titers into patients in need. And there's data that in some cases it may be helpful, and in some cases it may actually be fanning the flames and be worse. So this is a very complicated topic. It reminded me of the day a number of years ago at the ATA meetings when I went to the day-long session on Graves' eye disease. And I walked out far more confused after those talks than when I walked in the door. And this was the exact same feeling that I got, and that we're just starting to
Right.
understand this, but I don't see any promise that there's going to be a nice, clean answer where I get tested, I have antibodies, bam, I'm not shedding, I'm not infecting anybody else, and I am protected. I don't think it's going to be that simple.
Sure. Another question from our attendees and participants was to do with, you know, Allan, earlier you mentioned, you know, you've kept virtual visits going. I probably, you know, wanted to ask, you know, some of the other people to comment, Dr. Solórzano and Dr. McGill specifically, given that it's a private practice situation. So have you kept the virtual visits going at your institutions to keep the pipeline and the access open? Dr. Solórzano first.
We have been moving almost everything to telehealth or telemedicine. Clearly, it doesn't always work, so sometimes we end up on the phone and whatever we can do. Frankly, the number of visits has gone down. I think that Allan alluded to that, and I would be interested in seeing what everybody else's experience has been. So even though our templates are open, if you will, they're not necessarily filling up. Am I continuing to do telehealth? Yes. Am I continuing to do in person? For certain things, I have done in person.
For example, yeah.
An adrenal patient that preferred to come from the northern, you know, we border with Kentucky, obviously, and they came down from Kentucky to see me, and because I thought that the patient had adrenal cortical carcinoma, so the patient came in person because it was a big discussion. But could I have done that virtually? Probably, but I did not. So we do have very strict distancing right now in the waiting rooms, and actually, in fact, the waiting rooms are pretty much deserted. Yeah. The hospital is deserted. I think that's the same thing probably at your institutions.
Indeed.
So,
Dr. McGill?
Yeah, so we've been doing the telehealth as well, and it's been working pretty well. I was not facile at it 2 weeks ago, but we're getting better, and I've actually really liked the screen sharing function. So I will pull up all of their films before they come into Zoom, and then I can show them on the screen the parathyroid, where it is, and if they have a spec CT or something like that. So it's actually worked out very well. And the way that my office is planning on structuring is, some of those people said, yes, let's go forward with surgery. And so when they come onto campus, when we're ready to do these surgeries, like the parathyroid surgery, and they have to come for their pre-op visit, my office is a building away from where they would be going. So we're going to plan those things that they would then pop in, meet me in person, sign consents, and then the first time I actually saw them wouldn't be the day of the operation.
Mm-hmm. Well, while we're on the issue of telehealth and virtual visits, we have a question from one of our participants, Dr. Elfenbein, actually. Does anybody have any tips or thoughts about keeping fellows and residents involved and keeping their education going in this setting of video and teleclinics and limited OR time? Dr. Angelos, maybe we'll start with you.
Well, let me go on the record in saying I'm in favor of education. So, you know, what we've tried to do is maintain our engagement with residents and fellows with regular educational conferences. And so some of these are, you know, we are doing M&M as a Zoom conference. We're doing the resident lectures as an M&M conference. Even some of our clinical conferences, we have an endocrinology conference regularly. So we're trying to engage residents and fellows in that manner. Because I have actually not done an endocrine surgery case since the day that we shut down non-urgent, non-emergency cases, you know, there really haven't been any cases to do. I think that certainly you know, if I have the opportunity to do cases and as they ramp up, I do think that we want to be somewhat efficient because we've got to get out of the OR pretty quickly. On the other hand, I think you can do that while still allowing residents and fellows to participate actively in portions of the operation.
Anyone else have any comments on that?
I echo the same thing. We've Zoom, we all have learned more about Zoom. We have all our multidisciplinary tumor boards. We have we restarting our M&M. We didn't do the M&M until we could get permission, if you will, and we're restarting that this coming week. Grand rounds, our chief residents are giving their grand rounds. One of our stellar resident has been organizing the Zoom teaching for the residents, and it's actually been quite fantastic. Oral board style questions and didactics they're probably going to stay, honestly, from now. But the actual practice and getting into the operating room, that's difficult.
Yeah, we've tried to maintain as much of the educational curriculum as possible. And in addition to just kind of keeping the ball rolling, I think it provides an important socialization function. I mean, I'm having great fun seeing everybody's faces today who I haven't seen in a while. And I think the residents are the same way, in that they tend to be, you know, isolated. They're not running into each other. And just seeing somebody's face and interacting in a conference, I think, has a very positive value to it.
I want to say, though, that we didn't mention this, and I think you all probably experienced this, but during this whole crisis pandemic, it's been so important to communicate with each other, and at all levels, with the chairs, then with the entire department, and also with the residents on a regular basis, so that people can be heard and that things get clarified. So I just wanted to mention that, because I'm sure that everybody has experienced that. I hope that you have.
Excellent point.
While we're all living in the virtual world, we recognize that it requires a stable broadband connection and good access to internet. Don't the virtual visits per se increase the disparity that we're talking about in terms of access to care? I will have Dr. Lee address this first for me.
So I think that's a true statement. So I operate not only at Columbia, but also at a more community-based hospital up in Connecticut. And I think that's very true. So at Columbia, I would say 99% of our patients choose to have telehealth visits through a video-based platform. But in the Connecticut practice, I would say 99% choose to have a telephone call because they don't have access to a smartphone or other platform that's capable of doing a video chat. And then, you know, obviously language barriers, et cetera. So I definitely think that there is a disparity there, which can be overcome. So, you know, hopefully this will be changing soon in the next week or two, but, you know, not that we do this because of money or for billing or whatever it is, but, you know, obviously it's important to keep the lights on. So currently virtual visits done on a telehealth platform, a video platform, are reimbursed by insurers and Medicare versus telephone-based visits are not. It's been difficult to get those reimbursed in the same way as a standard visit. But that seems like it's going to be changing if it hasn't already passed through your state legislature.
Dr. Angelos, any thoughts on how the situation is in Chicago?
Yeah, you know, I mean, I do think that that you're asking about the disparities and the sort of accentuation of disparities is really an important topic. And I think that, you know, we have all seen the tremendous disparities in outcomes of patients affected by COVID-19. And, you know, I mean, we've seen in Chicago 6 times the death rate among Black Americans in Chicago compared to whites in Chicago. And, you know, what's really frustrating about this is that this is not new. We see these disparities in trauma care, we see these disparities in the care of diabetes, but it's very much accentuated now. And I do think that we should all sort of pause for a moment and think about what we can do to try to mitigate these things in the future. I think today, you know, my hospital would much prefer that I do video visits because we can bill more for them. But for some of my patients, that's not an option. And so, you know, I'm happy to do it over the phone. It sometimes takes a little bit longer and I get, you know, there's less reimbursement, but it seems like that's part of our responsibility. But I do think that going forward, we all really need to think about, you know, what can we do in our own environment to help mitigate these issues, which, again, they're not new, but they've had a spotlight shown on them by this current situation.
Excellent point. Thanks for that. While we're speaking about disparities, what about the ethical issues of rationing of care for endocrine as well as non-endocrine procedures?
Yeah, I mean, it's a great question. And, you know, again, I think that the issue of rationing is something that for many who practice in the US, this has not been an issue for us. We've not had to really think about it. But for many parts of the world, rationing is a routine aspect of daily life, and those decisions have to be made. In wartime situations, those decisions have to be made. To me, I think that, you know, there are different ethical bases that one can use to decide how to make these triage decisions. I think we have to realize that they are absolutely tragic choices when we have to choose between patients. And knowing that they are tragic choices, there's going to be moral distress associated with them. And so I think we need to think about what we can do to reduce that distress amongst caregivers. And so, you know, for us, and I think for most institutions, that is setting up triage teams that use objective criteria to decide who's most likely to survive and try to maximize the number of lives saved. And by taking that decision-making out of the hands of the care team at the bedside, I think that we can offload some of the distress associated with those decisions. And I think we all have to realize that if you are in a situation where you have to make those decisions, it cannot help but impact you in the future. And we know from the outbreak of SARS, you know, a decade or so ago, that the rates of depression and anxiety amongst caregivers who have had to deal with this were quite significant, 20, 30% in some studies. And so I think we have to be prepared for this, and we have to be prepared to provide the support to our colleagues and our coworkers about, you know, how to manage these things.
that was an excellent point that you brought up. And this was in fact discussed in terms of the budgeting that will be provided to healthcare providers, especially after this crisis. In terms of a big tragedy like 9/11, there was some funds that were allocated, and of course, there was always a shortage there. It's a great point that you brought up with regards to support for healthcare workers. I have a question coming in from India, wherein a resident asked me, what is the protocol for management of adrenocortical cancers, both in the setting of resectable lesions, and if unresectable, what would be the systemic therapy and how would we deal with it? I'd let Dr. Solórzano take that first.
So are we talking about in general or during COVID time? So one of the cancers in endocrine surgery that we believe are pretty urgent in nature, if anything, it's adrenocortical carcinoma. So that's the one that I don't think should probably be put off, particularly if resectable, because that's the only chance of cure for that patient. So if you saw a patient who you believe that has a high likelihood of having adrenocortical carcinoma in this circumstance, and the patient doesn't have, terrible comorbidities that a resection might lead to their death, I would imagine that I would offer that patient an operation. And after that, obviously, our usual management with oral agents to manage the patients, depending on the stage. If the patient presents with metastatic adrenocortical carcinoma, I would also manage the same way if possible. I don't know that that you wouldn't necessarily give that patient the current treatment because of the current times, unless the patient was exceedingly immunocompromised.
Thoughts from other people in the times of COVID, ACC in the times of COVID?
Yeah, I think you have to take into account all of those things, the clinical factors and your resources, right? So if you have a 70-year-old with lots of comorbidities and a resectable adrenocortical cancer, you sort of have to weigh their life expectancy, their potential outcomes, and then we have to weigh that against what your available resources are. And so, for example, if you have a patient, even a young patient who, like a 30-year-old who has adrenocortical cancer invading the IVC, you anticipate that they're going to need to go on bypass to, fish out a tumor thrombus from the atrium, all those things. I think all the clinical factors kind of play into it. And you sort of have to look at where you are on the curve. And again, these are very difficult decisions to make. And thankfully with ACC, we don't have to make them very often. But, I think you have to, there's no algorithm that you can use to say this ACC should or should not get an operation. Fortunately,
In our current situation here locally, we have the means to do that right now. Obviously, if we were overwhelmed, as James said, it would be a different time.
Indeed. One of the other questions that we've gotten is about triaging patients for virtual visits. And this is especially relevant to me as well, because until now, we had a phased input for video visits. We were able to do telehealth pretty early, but the video visit capacity has come sort of, triaging in certain clinics first, and surgery clinics were actually later rather than, the medical clinics. So we still have limited capacity. So when you have limited capacity for video visits, how are you triaging patients for video visits? Is it people who can wait for their surgery, but maybe anxiety and want to just speak to someone about it? Or what sort of considerations are going into those decisions?
I can take a stab at that. So previously, we did virtual visits for follow-up patients that didn't need to come into the office. So post-operative visits 6-month parathyroid follow-ups, and as well as new patients. And it was done on more of a convenience type of manner. Our current scheduling is that everybody is initially put on the schedule as a virtual visit. We review our schedules and then cherry pick the roughly 20% who actually need to come in for a fine needle aspiration or immediate pre-op visit prior to a surgery. So that's how we have flipped. And Peter nicely, mentioned, we've transitioned from using a HIPAA secure American Well platform, and very quickly ran into not only bandwidth problems as we rapidly expanded, but also got HIPAA waivers, so that we were very quickly able to then transition to non-HIPAA compliant FaceTime or Google Duo. And then the next one is just picking up the telephone and doing an audio only encounter. So I was very pleasantly surprised about how not only the insurers, but the governmental agencies very rapidly recognized the clinical need and the disparity need to liberalize our ability to provide care in that expanded way. In the future, many of our particularly our medical endocrinologists love spending the day at home doing virtual visits, and they're already asking, can I spend a day or two a week at home? I'll sit there and triage my schedule down the road, and those that don't need to come in, many of the diabetics, et cetera, I would rather save my commute, gas, wear and tear, et cetera, ability to go drop my kids off at school and come back and have a compartmentalized schedule. They're finding a great quality of life advantage in terms of doing that. Maybe a little bit less relevant to our practice, but I think this is going to fundamentally change the way we think about a lot of healthcare delivery. And I think it's going to overcome some of that disparity also, because there are a lot of patients who can't either take public transportation, drive, pay $12 in our parking lot, et cetera, to come in, and they've been resistant to get care. And now by literally just picking up a telephone, we can provide care that we didn't. So I think it's been a great education, not only for our patients, but in particular for our caregivers, that this is an effective model to deliver care.
Dr. McGill, how has this worked in the private practice setting? And I'll also follow that up with a question that we got from one of our participants, Dr. Calcaterra, that, how are you sort of triaging and commenting, figuring out how to do in-office FNA during this time as well? So the first part was, how are you triaging for virtual visits? And then also, what are you doing about FNAs? Dr. McGill?
So we're offering everybody the telehealth visits because I figure we're there and have the full schedule. But like Carmen said, I think the numbers are down across the board. I think people are even I'm taking emergency room call and you're not even getting calls. Your appendicitis people aren't coming into the ER. So the only people that are coming are like necrotizing fat, just terrible far end of the spectrum kind of for everything. And I haven't seen any real nodules or things that need to be worked up, because radiology is shut down. Mm-hmm. So all of these scans, you're finding things that would routinely be sent to us. So we're just, anybody who wants to come in for telehealth, we're putting them all on. And I figure at least we're then keeping the patient within the system, because I know there are some other people out in the community near me at freestanding operating places that are still doing things like belly button hernias. And so I think having the patients come in at least through telehealth keeps them within our system. So that's why we're trying to see everyone we can.
Very good point. Some of our we had another question about FNA, what's happening to people that do in-office FNA. Would like to hear your perspective on it in New York, Dr. Lee.
Yeah, so as with all good things in my life, Jen Kuo runs, is my partner, our multidisciplinary biopsy clinic. She's the director of our multidisciplinary biopsy clinic. And so Jen and the group have set together a very regimented routine where every patient who needs a fine needle biopsy will get a virtual visit. They'll look at the images as available, and they'll determine the urgency of the fine needle biopsy. So if it's, for example, like a small lesion that's not very suspicious, ATA, TIRADS, et cetera, they'll prioritize them a little bit later on the schedule. If you have a patient who you're trying to rule out thyroid lymphoma versus anaplastic cancer, obviously they need a biopsy immediately to get them to appropriate therapy. And so those are the patients that we'll prioritize for an in-office biopsy. And so if someone meets the criteria, rises to the level where they need a biopsy, then we stagger our practitioners in the office who do biopsies. So every couple of weeks, we change the person who's going to do the biopsy. Mm-hmm. So that way we have a couple of, like one incubation period before another practitioner takes over. So we're trying to mitigate that, the infectious stages and passing it on to the patients. And then obviously universal precautions, masks, et cetera. It's, I think, a testament to Jen's system that you not offer in-person biopsies up until this point. And I think she's done a great job of keeping track of all of those patients who need it. So that way, as we start to loosen the restrictions and we can start getting patients into the office, we'll just set up 2 or 3 biopsy days a week where each of us takes a day, and we just, hammer through all the biopsies that they've lined up. So I think it's a very good system to be thinking about triaging virtual visits in the short term, doing emergencies as needed, and then very clearly having a plan once things loosen up to absorb that volume again.
Great points. We have about 5 minutes or so left. So anyone else have any comments about the in-office FNA? Because a lot of people are interested about that. So Dr. Siperstein, Dr. Angelos, Dr. Solórzano.
So we're seeing the appropriate patients to do FNAs, and I would say that this is an area where we are combining both medical necessity as well as patient anxiety to do that clinical decision making. Personal protective equipment that is for both the caregivers and masks on the patients. It kind of brings up the question of risk of transmission from patient to caregiver. And we did a deep dive in our institution because we obviously have a number of caregivers who have tested positive. It's bad because you're not only got somebody sick, but you're also taking a much needed person away from the workforce. Doing the deep dive, it turns out, to make a long story short, that it's probably all community acquired, where we found that our caregivers were distributed among both those with patient contact, those without patient contact, desk clerks and billers and things like that. And that even those who were working on the COVID floors and ICU specifically, if anything, had a lower risk. Number one, because they were very compulsive about their personal protective equipment. They have spotters to watch them doff and don their equipment to make sure that there are no breaks in technique. And I would imagine when they go home and go shopping, they probably are the most cautious people in the grocery stores as well. And so we've actually seen that group, if anything, have a lower rate. And I'd be interested in particularly find out what Jane's experience has been in New York.
Yeah, I think we're going to find out the true answer to that. I mean, I think as all of you have seen, the denominator has not been consistent across the country, and I think certainly not adequately addressed. We just opened widespread testing for not just patients who are being admitted, but for any patients who are being evaluated. So I think we don't know the true denominator yet. But I think what you're saying is right, that the ICU staff, I think, hopefully will have very low rates of transmission. And part of it is because the patients come to us intubated almost invariably, so lessening the risk of aerosolation in that stance. But, again, I think as with many things with COVID, we don't really know the true extent of it yet. And probably in about 5 months, we'll know better what we're dealing with.
Okay. Thank you very much. In the last minute or so, I would like to ask a question that I think Allan brought up when we initially talked about this particular event. I'd like the panelists to share just in the last minute with our audience how they have been redeployed or repurposed during this period at their institutions. Since we have you on front, we'll start with you, James.
So I have to say that my institution has been very good about asking for volunteers first. And so there have been a minority of people who have been forcibly redeployed. So the Department of Surgery, it's gratifying to see that the vast majority of surgeons volunteered to be redeployed elsewhere. So I've been volunteering in our makeshift ICUs that, they converted operating rooms into ICUs, and with our procedure team that kind of goes around the hospital, doing procedures throughout.
Dr. McGill?
Well, in Georgia, we're still a few weeks behind, so we're kind of waiting to see what's going to happen. But they've asked for capabilities and what you would feel comfortable for doing, and talked about similar teams that James talked about, teams that would be capable of doing lines and things like that. But we have not had to do anything to this point.
Allan?
So all of our physicians, we have basically a triage list, and so all the caregivers are ranked in terms of first, second, third to go be repurposed. Several have volunteered for various types of activities, but we've not needed to go into that pool yet. Obviously, with some of my duties, I am in administrative and planning meetings far in excess to what we have done before. And I think it was brought up very nicely by Carmen, is that I think communication is very clear. And so if anything, our institution has worked very hard to communicate at all levels, to be very clear and transparent about what the current state is, what the plans are, because I think a huge amount of the anxiety has to do with uncertainty.
Dr. Angelos, at Chicago, how has the redeployment of endocrine surgeons occurred?
Yeah, so so far we haven't been hit as hard as some places, and so I've been taking some general surgery call. I've had more people want to talk to me about ethics in the last 3 weeks than in the entire prior 50-some years of my life, and so that's been interesting in a very different way. And I'm on call as one of the 3 ethics people in the hospital if we actually have to make these tragic choices. So so far we've escaped needing to make them, but I'm prepared if we have to.
Well, we appreciate that you're part of those hospital incident command systems, Dr. Angelos.
Thank you.
Carmen?
So the surgeons have not been redeployed yet. The way we did it at our institution is we paid attention to some other folks and what they had experienced. And even we called folks in New York, even at Columbia, to find out how they've been dealing with this. But so a survey was sent, a red cap survey to certainly the entire surgical faculty, to find out if folks were comfortable with ward medicine or not, or could learn also with ventilators or lines, etc. So with that, we have a whole list of folks, and facilitated by some excellent other surgeons that volunteered to do this. If you said that you were not comfortable with a ventilator, but you were willing to learn, we did courses essentially online to refresh. So we have a list. We have not deployed. We have teams, but thankfully we have not had to deploy. But everybody was very, very ready to do their part. Has been.
Of course, we're surgeons, right? So
yes.
Well, I think we're out of time and maybe a little bit over time. So I just want to take this opportunity to thank all of you for taking time out of your evenings to help us connect again as our endocrine surgery community. The chat, you know, a lot of people have said it's so nice to see people's faces again, and I take that as encouragement that our first session, you know, was well received, and we'll work, you know, with the IT committee. We'll try to organize more of these, and maybe next time the panelists can that we have, you know, maybe we'll make them virtual wine sessions. You know, I don't know, happy hour.
Perfect.
That's a great idea.
So I want to thank Lauren for helping us put this together on such short notice and getting sort of our technical things set up, and my co-moderator Rohit, and all of you, Allan and James in particular, for supporting this endeavor. So thank you.
Great,
Have a
thanks.
good
Be
night.
safe. This has been
Excellent
fun.
Thank you so much.
Good seeing everybody.
Good night. Thank
Thank
you.
Good night.
Good night and be safe.
Thank you.